My name's Dr. Mullally. I'm one of the haematologists at the Whittington and UCH. I was asked to kind of talk through some case studies in cardiac and liver disease in haemoglobin disorder patients. Obviously, it's quite a broad topic to cover, so it's not possible for me to cover the full range of everything, but I've kind of picked 3 cases which highlight some of the kind of more, I guess, important or common complications in patients with sickle cell disease and thalassemia. So I've got 2 sickle related cases and 1 thalassemia related case. So the first case actually based on a patient that I used to look after in Nottingham, who is a 60-year-old male with SS sickle. They've got some comorbidities in the form of renal impairment, a previous splenectomy, but in terms of crises, fairly infrequent. They've had historical antibodies, both anti-big K and anti-big E, which actually you can get around with antigen negative blood, which is not particularly difficult to find for that kind of type, and no history of transfusion reactions or hyperhemolysis. The main issue they were having was they had recurrent admissions with shortness of breath and pulmonary edema, so kind of almost left ventricular failure kind of presentations in the previous 12 months. They were a prisoner, which kind of meant that I think they didn't really kind of get taken out of the prison until they were in a kind of extreme state. So it's very difficult to kind of manage their heart failure in a more kind of ambulatory way without hospital admission. He had a very hemolytic phenotype with the baseline hemoglobin of 40 to 50, and his renal impairment was probably contributing to that. It had been felt too difficult logistically by a predecessor to transfuse him regularly, so he'd been put on hydroxycarbamide and high-dose erythropoietin, and even with a very high dose of erythropoietin to kind of overcome any endogenous EPO, he didn't have a great response, to be honest. And then in clinic, he had features of heart failure. But he went on to have an echocardiogram, which showed some significant LV impairment, extremely dilated chambers, significant MR, which was felt to be kind of functional by virtue of the kind of annulus of the mitral valve being pulled apart by how big the cardiac chambers were, and a raised estimated pulmonary artery systolic pressure suggestive of pulmonary hypertension, and an extremely kind of hyperdynamic left ventricle, which kind of on a high output state in view of his significant anemia. As you might expect, his BNP was significantly elevated, and as part of investigations of other causes of his pulmonary hypertension, which I'll go on to talk about in a minute in terms of the general approach to a patient with this sort of problem. VQ scan didn't show any evidence of kind of perfusion defects, and previous chest imaging had shown that he didn't have any significant signs of kind of sickle lung disease. We found a helpful cardiologist to undertake a right heart catheter, and that confirmed pulmonary hypertension. So what did we do, and what do you do in general for patients such as this? So I mean, there's a range of cardiac complications that you can see in patients with sickle cell disease. Pulmonary hypertension is the one everyone thinks about, and it's kind of the main reason that we kind of do echocardiographic sort of surveillance screening for it. But there are other issues that can happen. So you can get cardiac failure without any ischemic heart disease, so kind of a non-ischemic cardiomyopathy, and that can happen with a preserved or impaired ejection fraction. So you can have heart failure with a preserved or heart failure with a reduced ejection fraction. And obviously one of the other things that we're kind of is coming through more now is actually patients with sickle cell disease who have concomitant ischemic heart disease, and that can happen for all the standard risk factors that anyone else could develop ischemic heart disease. That would include, you know, hypertension, diabetes, hypercholesterolemia. And obviously that's partly a result of patients who have sickle cell disease living longer, and it wasn't something that was seen so much in the past. What I would say in comparison to thalassaemic patients, it's unusual to get cardiac iron loading in patients with sickle cell disease, even in patients that are heavily transfused and have high liver iron concentrations. And that's because they've got lower non-transferrin bound iron levels compared to patients with thalassemia. And also probably on a kind of statistical level, most patients who are adults who are chronically transfused are transfused via exchange rather than top up. So in theory, although obviously we know that not all patients on exchange programs have either iron neutrality, in theory it's kind of less iron loading. So in terms of pulmonary hypertension in sickle cell disease, kind of various population-based studies have estimated this to be between 6 and 11% of adult patients. There's various types of pulmonary hypertension, which I'll go on to talk about in a minute. But the most common types seen in patients with sickle cell disease is types 1 and 2. The treatment really depends on the type of pulmonary hypertension, which is defined by the cause and also the kind of dynamics that are seen at right heart catheter and the measurements taken. And in general, the sort of patients that are more likely, who have sickle cell disease, are more likely to get pulmonary hypertension are patients just like this man who I used to look after. So patients who are older, patients who have coexistent renal impairment, patients who have hemolytic phenotype, patients who have got a low baseline hemoglobin, because obviously if you're very hemolytic, there's more kind of vascular damage from the hemolysis, a microvascular level, and if you're more anemic, then obviously that's a bigger strain on the heart in the longer term, so that you kind of get a higher output state for longer, which can then progress into heart failure. Regardless of how you classify it and what the cause is, if someone who has sickle cell disease has pulmonary hypertension, it increases their mortality risk. So these patients generally have lower life expectancy. This diagram kind of just summarizes all of the different reasons that might happen, but I'll talk through that in the different types of pulmonary hypertension. So sorry for this being a bit wordy, but these, obviously you probably get a recording of this or copy of the slides that you can read through in a bit more detail. But in summary, type 1 pulmonary hypertension is where the arteries and the lungs get stiff and cause stress on the right side of the heart, and that's most commonly seen in patients with connective tissue disease. So if you think about patients with things like scleroderma, it also can happen in HIV and in drug-induced causes. And this is generally the type of pulmonary hypertension when people think about kind of therapies, vasodilator therapies for pulmonary hypertension. Other types don't respond to this quite as well. So things like bisentan and phosphodiesterase inhibitors, and which would include sildenafil, can be useful in those patients. And interestingly, when a trial was done looking at sildenafil in patients with sickle cell disease, there was actually an excess of adverse events in that population group. So we're very careful about who we give sildenafil to in the context of pulmonary hypertension in sickle cell disease. The second type, which is the most common in general, is pulmonary hypertension due to a kind of primary cardiac issue, so a left-sided heart issue. Obviously, everything is connected. If your the left side of your heart is failing and not pumping enough out with each beat, then there's a backup basically. So you have this pooling of blood in the left side of the heart, which backs up into the returning side, which is in the lungs, and then you get high pressure in the lungs. The treatment for that is to treat the heart failure itself, or the cause of the heart failure. The third type is pulmonary hypertension due to lung disease, and again, patients with sickle cell disease can have any type of pulmonary hypertension. So in this context, someone who has like an interstitial lung disease or chronic sickle lung disease, or sleep apnea, can develop this type. The fourth type is chronic thromboembolic pulmonary hypertension, which the mechanism of that is fairly simple. Chronic clot in the pulmonary arteries causes increased resistance in the pulmonary arterial circulation, which the right side of your heart pumps against, and therefore the strain and long-term strain and pressure increases on the right side of the heart. Obviously, we know that clots are more common in patients with sickle cell disease, and this is the type that can be treated with pulmonary endarterectomy in certain patients. And then type 5 is kind of either whether the cause is mixed or not. It is not known. So in the official classification, sickle cell disease is stuck in here because there are patients with sickle cell disease where no other particular reason can be found other than the fact they've got sickle cell disease. So in terms of the role of the right heart catheter, we can't say conclusively that someone has pulmonary hypertension based on an echo measurement alone. It's kind of the tricuspid regurgitant jet velocity, which I'll go on to talk about in a minute, is a surrogate marker, and the gold standard is an invasive right heart catheter, and is defined by a mean pulmonary artery pressure of 25 millimeter mercury or more. And they then classify the pulmonary hypertension either post or pre-capillary based on the hemodynamics seen at the right heart catheter, and that also also predicts the response to treatment. So the pre-capillary types are more likely to respond to kind of treatment that involves vasodilators, so things like the bosentan and the phosphodiesterase inhibitors. Type 2, which is post-capillary, is actually the commonest group, so it includes all the patients who have got pulmonary hypertension due to left-sided heart issues, which is what this patient had. Doesn't respond to vasodilator therapy, so he wasn't eligible for that. So what did we do for this patient? It was felt that essentially he also had an invasive angiography to exclude ischemic heart disease given his age. So he had a non-ischemic cardiomyopathy secondary to his chronic anemia, and as I said, the mitral valve disease was felt to be kind of functional from the stretching of his heart by the dilatation of his chambers. As I've just said, not thought to benefit from pulmonary vasodilator therapy. We admitted him for intravenous diuresis down to a dry weight because we weren't able to kind of do that in an ambulatory way, given that he was a prisoner and he lost several kilos. So his actual baseline weight that we thought was his baseline weight wasn't at all. It was about 7 kilos less than we'd ever achieved before, but that was just by aggressive diuresis. And I would highlight the importance of actually kind of interested and engaged cardiologist in this kind of case, because they were kind of prepared to give doses of diuretics that I would have felt uncomfortable with myself. And also, you know, they had expertise and access to newer therapy. So this man had Entresto added, which is a newer drug. It's been around for a few years, but in the kind of general management of heart disease. So in patients who are already on a beta blocker or an angiotensin receptor blocker or an ACE inhibitor, either the maximum dose or the maximum tolerated dose, you can add that in. And we also decided, and again, it was useful to have the right heart catheter result in making the decision to actually put him on regular top-ups and then later chelate him when he developed iron overload. We felt that his baseline hemoglobin was too low really to easily exchange him, because it was in the kind of low 40s, early 50s. We kind of thought about he had very low blood pressure at baseline, and again, you can obviously drop your blood pressure when you're having an exchange, so we didn't want that to happen. Also, his vascular access was not good at all. He wasn't keen on intermittent femoral lines, and he would have been difficult to even do deep vein ultrasound guided cannulation on. So we actually put a PICC line in and administered top-ups, and the idea of that would be to raise his baseline hemoglobin, increase his oxygen delivery capacity, and reduce the strain on the heart. We gave kind of fairly eye-watering doses of diuretics to cover the transfusions, which we managed to kind of get cross-matched on the day, with lots of coordination from our CNS with the kind of prison health team. If anyone's ever had to kind of try and get patients to come on time for an appointment from a prison, it's quite challenging, but we managed it. So he needed to be with us at kind of 8 in the morning, have his cross-match, and then be transfused 2 units slowly with 120 milligrams of furosemide IV given over 2 hours before the first unit of blood. But with that, his baseline oxygen saturations returned to normal. This is over kind of, you know, weeks and months from being hypoxic all the time. He didn't get admitted he hadn't since we instituted this, and when I left back in 2021, he hadn't been admitted since, and that was at least a 12-month period. On repeat imaging, his ejection fraction improved. His mitral regurgitation, even to listen to, went away. You could actually hear that the murmur had resolved, and the chambers of his heart shrank, which I find quite satisfying, really. So what do the UK standards tell us to do about pulmonary hypertension or looking for it? So obviously part of the annual review is to well, pre-COVID at least, and hopefully getting back to it now, is to physically examine your patient and ask them about symptoms that are relevant in this respect. So things like shortness of breath, particularly on exertion, any syncope, pre-syncope, chest pain, ankle swelling, so all signs of cardiac issues. Obviously, you wouldn't necessarily get chest pain with pulmonary hypertension itself unless you had ischemic heart disease as well. But general cardiovascular review is important, at least annually. To clinically examine the patient, murmurs, JVP, peripheral edema, hepatomegaly, so any signs of heart, listen to the chest, any signs of heart failure, and then regular echocardiography. And generally, unless there's an indication to do so before transition to adult services, it's unusual for a patient, unless directed by symptoms or other issue, to have had an echo before they're an adult. And then thereafter, 3 to 5 yearly, people's practice varies. So some units will do an annual echo, some even in the absence of any symptoms or signs, but most units would do 3 to 5 yearly. And the advice to refer to a pulmonary hypertension service, at least in the UK standards, will be if the tricuspid regurgitant jet velocity is over 290 centimeters a second, or 2.9 meters a second. Or if those have a measurement between 250 and 290 with symptoms. And the tricuspid regurgitant jet is actually measured from the echocardiogram itself, so from Doppler echocardiography. So it's a measure of the speed of the blood that moves back into the right, back into the right atrium from the right ventricle when it pumps. And it's a surrogate marker of right ventricular systolic pressure and pulmonary artery systolic pressure. But like I say, it's got its limitations in terms of the echocardiographic measurement. So it's not a gold standard. As I said, the right heart catheter is. The actual pickup rate is relatively low. So the higher you set your threshold of tricuspid regurgitant jet velocity in terms of referral to a pulmonary hypertension service, the more patients that you might pick up. So if you set the threshold at either 3 meters per second or 300 centimeters per second, more of those patients that you refer will genuinely have pulmonary hypertension. But in order to capture everyone, that's why the thresholds are set lower. And even in those patients where they have a raised tricuspid regurgitant jet velocity, but no convincing evidence of pulmonary hypertension on a right heart catheter, just by having an elevated tricuspid regurgitant jet velocity itself is an independent marker of increased mortality risk in patients with sickle cell disease. So there is a value in measuring it just on that basis, probably. In terms of what happens in an acute sickle crisis, even if you don't have a clinically overt chest syndrome at the time, your pulmonary artery pressures are likely to rise during that time. So I would always take like the measurement of an estimated pulmonary artery systolic pressure done in the context of an acute crisis with a pinch of salt. And usually what we would recommend is that you then repeat that echocardiogram several weeks at least later when the patient is in a well or steady state to see if that measurement goes down, rather than kind of knee-jerk react to that measurement based on an echo done during an acute crisis. So that's the American guideline for referral, which I'll skip over just in the interest of time. It is very similar to the UK, apart from it incorporates a few more tests, such as the 6-minute walk test. And as I've said, management really depends on the type of pulmonary hypertension. But in general, regardless of the cause and whether it is or isn't one that will respond to kind of directed therapy with pulmonary vasodilators, the general consensus would be that anyone that has sickle cell disease and pulmonary hypertension from any cause is at higher risk of mortality, and in some way you should modify their sickle cell disease if they're not already on disease modifying treatment. So hydroxycarbamide is frequently used. It's recommended in the as first line in American guidance. I mean, I think lots of UK clinicians may actually have a preference towards transfusion for patients. And certainly there are a number of patients that we look after here who are on exchange transfusion, the indication being pulmonary hypertension. There's kind of cohort study and case series data on outcomes, improved outcomes with that, but there isn't currently a randomized control trial, although one is planned. So just moving on to my second case, this is a thalassemia based case. So this is a case of a patient from the Whittington, who's a 26-year-old male with transfusion dependent beta thalassemia, who attended for a routine cross match and mentioned to the nurse on the thalassemia unit that they had previously been found by their brother on the floor with no memory of events the night before. At the time of being seen by the nurse, they felt fine, but on further questioning reported skip beats for the last month and dizzy spells. We know, based on this patient's serum ferritin levels and previous imaging, that they've got poor compliance with chelation, and they're currently on single agent oral XJ, but haven't been good at attending clinic reviews. This is a graph of their serum ferritin. As you can see, it's on average climbed over time, actually from a high baseline to start with, but is well over 10,000 at the time of being assessed. An urgent EGT is undertaken on the day unit, which shows a prolonged QT interval. They're discussed with the consultant admitted, and obviously the concern here is that they're having runs of arrhythmia, which you would worry about a ventricular arrhythmia with this sort of presentation, and indeed cardiac monitoring as an inpatient shows runs of non-sustained ventricular tachycardia. An urgent echo is requested, and an urgent repeat cardiac T2 star MRI is requested to assess their cardiac iron burden. And a provisional plan for a PICC line to give IV desferel and then oral deferiprone subsequently is made. So this is the ferry scan for this patient, as you can see, greater than the upper limit of normal that can be measured. In terms of, you just obviously had a talk on the T2 star and ferry scan, but as you know, the higher the number, the better in a T2 star versus ferry scan for liver is the opposite. The higher the number, the worse the liver iron loading. So this guy's got an extremely high liver iron concentration on ferry scan and an extremely low T2 star measurement. His echocardiogram showed a mild LV impairment of an ejection fraction of 52%. Now, the translation of a very high cardiac iron burden in someone with thalassemia into clinical heart failure takes quite a long time. So it takes a long time to load the heart with iron. It takes a long time to get it out. But you also have to bear in mind that ejection fraction of 52%, relatively compared to what a normal baseline for someone with thalassemia should be, is low. Because patients with thalassemia often have a supranormal ejection fraction because of their chronic anemia, even if they're transfused. It's more of a problem in patients that are non-transfusion dependent, having a higher cardiac output, but it would still be normal for someone with transfusion dependent thalassemia to have a supranormal ejection fraction. So that 52% still is a relative reduction in their ejection fraction. And obviously patients with a T2 star of less than 10 is where they're at risk of significant complications, including decompensated heart failure, and if it's less than 6, that's even worse. So the type of cardiac complications overall that you get in beta thalassemia again can be varied, but it still remains the leading cause of death in this patient group. More than infections, liver disease, and hepatocellular carcinoma, more than thrombosis, more than endocrine complications. As an absolute number, the number of deaths in patients with thalassemia from cardiovascular complications has reduced, and that's due to generally better care. But that's obviously not the case worldwide, and there's still areas of the world where chelation is not is poorer, and so this sort of problem is much more common. And the other causes of heart problems in patients with thalassemia can be related to chronic anemia, so similar to the case of the gentleman with sickle cell disease I discussed, with a very low baseline haemoglobin, and that can be a problem if you're inadequately transfused, either due to compliance issues or access to adequate transfusion. It can also develop in non-transfusion dependent thalassemia patients as a kind of chronic high output cardiac failure state. Obviously, in this case, we're talking about iron cardiomyopathy, and as I mentioned with the sickle cohort, there is more kind of standard atherosclerotic disease and ischemic heart disease coming through for the same reasons that can happen in other patients. Obviously, patients with thalassemia have got a higher incidence of diabetes, which can contribute. Other things that kind of contribute to the cardiac injury that can occur in patients with thalassemia can include if you've got concurrent liver cirrhosis, which also causes a relatively high cardiac output state. Extramedullary hematopoiesis again causes a high output state because you're pumping blood through a kind of very vascular areas of additional bone marrow, and stress on the heart from any thromboembolic disease and pulmonary hypertension, which is also more common in patients with thalassemia, particularly patients who've had a splenectomy, and particularly pulmonary hypertension is more common in non-transfusion dependent thalassemics, so we do have to look out for it. And I think I've covered that already. Okay, so I've already talked about this idea of having a supranormal ejection fraction in the steady state in patients with thalassemia. The types of cardiomyopathy you can get can be either a hypokinetic cardiomyopathy where you have reduced cardiac function without any dilatation, so heart failure with a reduced ejection, with a preserved ejection fraction, or a reduced ejection fraction. In a hypokinetic, it will be reduced ejection fraction. So in a restrictive, it will be a preserved ejection fraction. And you can get that in like an infiltrative iron cardiomyopathy. You can get either. As I've also said previously, it takes a long time for you to get a reduced cardiac function, even when your cardiac iron levels are very high. And so the tipping over the edge can happen fairly acutely sometimes, and can often be precipitated by another stress such as infection. This diagram is taken from the Thalassemia International Federation guidelines, just that kind of details all the different mechanisms that you can get a myocardial injury in thalassemia. In terms of how to manage this patient, I'd already kind of alluded to the fact that he was going to get a PICC line, IV Deserel and deferoprone. So deferoprone is particularly useful in combination with either Exjade or Deserel in removing cardiac iron, and I'll come on to that shortly. And I've already talked about that. So when the T2 star is less than 6, that's when you're even higher risk, and you get. I'll show a graph in a second with the relationship between the T2 star value and the risk of heart failure. So it's obviously not linear in terms of the increase in the cardiac tissue iron. So once the T2 star goes below 10, you see this kind of almost, well, it's not quite exponential, but uplift in the rate of cardiac tissue iron loading. So you get more and more and more and more, and the risk of heart failure increases. I think Maciek's probably talked about this already, but in terms of suggested monitoring intervals with a T2 star. So if someone's got a T2 star greater than 20, which is where there's no significant cardiac iron, we would generally do it 2 yearly, unless any ferritin measurements in the interim or a ferriscan done by itself kind of suggests that the patient's iron control's worsened, and then you may want to do one in the interim. 1 yearly if the T2, sorry, that's a typo, they're not 1 to 20, that should be 10 to 20, and 6 monthly if the T2 star is less than 10. The sort of doses that you would use for deferoprone is higher than standard dosing. So you'd use a dose of kind of 50 to 60 milligrams per kilogram as a continuous 24-hour infusion. And then you add deferoprone in at the standard kind of dose, 75 to 100 milligrams per kilogram a day in three divided doses. Obviously, if you're going to put a PICC line in someone with thalassemia, you might want to consider the thrombotic risk of that, and locally we would certainly, unless there was an indication not to, we would normally give the patient a low dose DOAC, so something like 10 milligrams of roxaban once a day, or 2.5 milligrams of apixaban twice a day. There are recent BCSH guidelines, which Maciek may have also alluded to, that kind of break down the management of myocardial iron overload in patients with thalassemia and rare inherited anemias. And the tables in this guideline are quite helpful in that they split the management strategies between whether you've got normal ejection fraction, so normal cardiac function or not, and what your cardiac T2 star is. So in this case, obviously the first line would be high dose desferrioxamine as a 24-hour infusion, and adding deferriprone in. The choice of agents would also depend on patient individual factors. So what their preference is, what they're prepared to tolerate. Some people will obviously refuse a PICC line and IV desferel. What the previous experience of any toxicity from chelators is. So if, for example, if someone's had neutropenia from deferriprone before, or if someone's had severe ototoxicity or retinal issues with desferrioxamine, so you may have to choose, a regime that wouldn't be your first choice on paper, which you have to adapt to the patient's individual characteristics. So just to finish with a third case, so obviously talked about 2 cardiac cases, and I'll have to talk a bit about liver disease as well. So this is a patient from King's College Hospital, a 24-year-old male who has homozygous sickle cell disease, previous gallstones, and had the gallbladder taken out, history of priapism that has subsequently resolved as the patient's got older, gets admitted a lot with vaso-occlusive crises, but has failed to tolerate hydroxycarbamide in the past, is not on any other disease-modifying therapy. So this is in the pre-crizanlizumab era, and the patient is not currently on regular red cell exchanges at this time. There's no history of alcohol excess, obviously relevant to liver disease. And the issue is that it's been noted that this man's transaminases have become more abnormal over time, and his baseline bilirubin has increased gradually over time. And when a split bilirubin has been done, the picture is more of a conjugated than unconjugated picture. And obviously in hemolysis, normally it would be predominantly unconjugated. So there's thoughts that there may be an intrinsic liver problem here. He then presents acutely with abdominal pain in the right upper quadrant, increased jaundice, increased jaundice and a low-grade fever. His bilirubin is increased from a baseline of around kind of 80, which had increased anyway over time to over 300. Transaminases have grossly increased, as has alkaline phosphatase. Coagulation screen is normal. A CT scan shows an enlarged liver, which is larger than on previous imaging. Mild intrahepatic duct dilatation, which may be a post-cholecystectomy feature, and patent hepatic vessels. And the importance of that is that obviously, you can get an acute liver injury if you thrombose vessels around the liver, so in the kind of Budd-Chiari type problem. But this is in the context of a sickle crisis, and it's felt that he's got an acute sickle liver. He's treated with intravenous fluids and an exchange transfusion to get his hemoglobin S percentage down below 30%. And then he makes a recovery, but a good clinical recovery. But over time, subsequently, his clinical course is punctuated by similar episodes to that just described, and a progressive cholestatic picture in his liver function tests. Other causes of liver dysfunction are looked for, so his virology is done in terms of extended hepatitis virology, or negative. Autoantibody screen is negative, so obviously autoimmune disorders are more common in this patient cohort, so it's not impossible. I've seen a number of patients with autoimmune hepatitis and sickle cell disease, and he's also evaluated for any transfusion of previous transfusional iron. It's obviously not transfused regularly at the moment, but previous transfusional iron burden, and a level of 5.9 milligrams of iron per gram of liver dry weight is really only mild iron loading and not enough to explain the current clinical picture. And normally you kind of you wouldn't necessarily chelate someone at that level. This graph just shows kind of the upswings in his bilirubin and ALT over time, which kind of mirror each other on the background of the baseline raise. Imaging of his liver included a triple phase CT scan and liver MRI. So you can see on the left hand side that the liver's enlarged, occupying most of the abdomen there. There's an irregular edge suggestive of chronic liver disease. And I guess on the MRI image on the right, you'll have to take my word for it that the biliary ducts there are dilated, and the picture, it's obviously it's not zoomed in enough, but there's a degree of cholangiopathy there, so it's got like scarring and scarring of the biliary tree. In terms of his clinical progress over time, he was established on a regular red cell exchange program, ursodeoxycholic acid, which can be helpful in hepatic cholestasis, and obviously is used in lots of other conditions. So, like for example, primary biliary cirrhosis. To help with that, he even had hydroxycarbamide added in as his LFT deteriorated, despite the exchange transfusions. Despite all of this, the patient developed decompensated liver disease and ascites, and was referred for liver transplantation at the point where his mortality from his liver disease was predicted to be above 20% at 1 year. Obviously, to be fit for a liver transplant, lots of other things need to be excluded, such as sickle, lung, and heart disease. And thankfully, he didn't have any significant other comorbidities, so was felt to be fit for the transplant. The transplant was unremarkable in itself. Obviously, he had a red cell exchange timed very close to the transplant itself, which would be standard practice for major surgery in any patient with sickle cell disease who is able to be and consents to transfusion. As an aside, when you're looking at bilirubin levels in a patient with sickle cell disease, so obviously that was one of the first things that was picked up in this patient's clinical course. We need to think about the relative contributions of the unconjugated and conjugated fractions. So hemolysis itself really is predominantly unconjugated. If there's a very high conjugated level, then think more about an intrinsic liver problem. It really does vary depending on the individual patient, what their normal bilirubin runs at. So it's important to look at historical results, particularly comparing what they're like in clinic when the patient is well versus what happens to the patient's bilirubin when they're in with a vaso-occlusive crisis, which will obviously increase it. I guess the other things to think about are if you have a massive increase in the unconjugated fraction, has the patient been recently transfused, as obviously both delayed hemolytic transfusion reactions and hyperhemolysis will put the bilirubin up. It's also important to mention that some people have got coexistent Gilbert syndrome, which is an issue with conjugation that increases, it's an inherited condition that increases the unconjugated bilirubin at baseline. So in some patients where you have an unexplained high resting baseline bilirubin, you might want to test for that as well. In general, in liver disease and sickle cell disease, just having abnormal liver function tests doesn't necessarily mean that you've got established liver disease. AST might also go up as a consequence of hemolysis. You can get acute complications relating to the liver in sickle cell disease, which includes intrahepatic cholestasis and hepatic sequestration. The difference between these two things is that in hepatic sequestration, you tend to get enlargement of the liver, but not significant derangement of your transaminases, and it normally responds to top up. Whereas intrahepatic cholestasis is more of a fulminant picture, where you also get coagulopathy, extremely high conjugated hyperbilirubinemia, transaminase derangement due to intrasinusoidal sickling. And this really is an indication for an exchange transfusion rather than just a top up. Usually in hepatic sequestration, a bit like a splenic crisis in a child, the bilirubin tends to the hemoglobin tends to drop enough to be able to top the patient up out of it. Whereas intrahepatic cholestasis really is an indication for an exchange transfusion. In terms of patients who have, like this gentleman I've discussed, a progressive chronic picture felt to be related to sickle cell disease, where other causes of liver disease have been excluded, the usual practice will be to start the patient on red cell exchanges to protect their liver, which was exactly what was done in this patient. Overall, only small numbers of patients progress to liver transplantation, partly because sometimes additional treatments such as red cell exchange stops the progress of the liver disease, but also there were a number of patients that unfortunately are not fit for liver transplantation due to other comorbidities which may or may not be related to sickle cell disease. It's important to have a broad mind. I mean, as with anything in patients with sickle cell disease, not everything that can happen to them medically is attributable to their sickle cell disease, and sometimes you need to look and see beyond that. You can obviously get liver dysfunction from right heart failure, which can happen in patients with sickle cell disease. Coexistent autoimmune disease is more common. So recently had a patient at UCLH with sarcoidosis causing liver impairment and kind of presenting like a sickle hepatopathy, which has responded to steroids. Liver disease from the reasons that other people get liver disease: fatty liver and diabetes, alcoholic liver disease, drug-induced causes, although it's usually more of an acute picture, iron overload causing liver disease, and hepatitis from any other cause, but would include from blood transfusion. So, for example, hepatitis C. So this table just kind of summarizes the kind of different causes of acute and chronic liver disease in patients with sickle cell disease. And just my final slide to talk about the role of liver biopsy, which has been conspicuous by its absence in my talk so far. Essentially, we don't really do a liver biopsy and unless we feel that it's going to change management or there's significant diagnostic uncertainty. The reason for that being is that if other causes are reasonably excluded, then the most likely cause is sickle cell disease itself. And the risks of a liver biopsy are much higher in patients with sickle cell disease compared to other patients, particularly from a bleeding point of view, and particularly if you did a liver biopsy during an acute episode. If biopsy is pursued, then it should be done by a transjugular route, ideally, which, although sometimes the histology is not as good, is much lower in terms of bleeding risk. So it's actually quite unusual to do a liver biopsy these days. But for example, in patients where it's felt that the liver disease might be autoimmune, that might be one of the few instances where a liver biopsy is considered, because it would change management in terms of giving immunosuppression, steroids, etc., rather than sickle directed therapy. Those are my references, and sorry, I've gone a bit over time there. So I'm going to stop now, and if there's time for any questions.